Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Satya Maharshi, gastroenterologist at AIG Hospital, Hyderabad, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Myself, Dr. Satya Maharshi. I'm a consultant gastroenterologist in Asian Institute of Gastroenterology, Hyderabad. I'm working here since 3 years as a consultant gastroenterologist.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
Exactly, IBS is we say it as irritable bowel syndrome. That means it looks normal on the blood test. When the patient says many complaints like I'm having bloating, abdominal pain, they come to us in the OPD. They say like bloating, abdominal pain, diarrhea. Some few people say constipation. But everything looks normal on the test actually. But his gut is not functioning normally. So to say understand to the layman or like common public, everything looks normal on the test, but still the gut is not working normally. That is called as irritable bowel syndrome. To summarize, it is a functional gastrointestinal disorder where everything looks normal, but patient is not having good quality of life.
Is IBS really a stress disease, or is there more to the story?
To say this, PD, I can say, honestly, I can say 90%, not exaggerating, 80 to 90%, there is definitely a stress factor, one of the major contributing factor to irritable bowel syndrome, but that is not the only causative factor for the IBS. There is a lot more. IBS is a big term, actually. It involves actually a complex interaction that is called as complex interplay, not interaction, interplay between our gut and brain actually. What happens exactly is our gut, that is called our intestine, and brain are interlinked. When there is a dysfunction between this, that is called as gut-brain axis dysfunction. That is one of the major contributor. Second thing, when there is an altered motility in your gut, that means when there is a movement disorders, altered motility in your gut. And third thing is visceral hypersensitivity. And fourth thing is patients with gut microbiota changes. That is called as gut dysbiosis. All these factors will contribute to irritable bowel syndrome. Not only a stress, actually. Stress one of the contributing factor, but is a complex interplay between all these factors that called as irritable bowel syndrome.
What are the top 3 red flags that make you suspect IBS in a patient?
Red flags, symptoms that will suspect IBS in a patient is in a OPD, if patient is complaining of recurrent abdominal pain, that too chronic history associated with sometimes diarrhea, might be associated with constipation or mix of these symptoms. So with impaired quality of life, then I suspect this patient has a irritable bowel syndrome. Most important sign is patient should have a recurrent abdominal pain that is associated with the bowel movements.
How important is the patient's history compared to investigations in IBS diagnosis?
A detailed patient history is the cornerstone to diagnose IBS actually. It's not about investigations. IBS is usually a positive clinical diagnosis. It's not about investigating the patient with the history. A detailed history itself will give you will get an idea whether we are dealing with an irritable bowel syndrome or we are missing some organic disease. So first of all, when a patient in OPD, you are seeing this history of this chronic history, that is, patient is suffering with chronic history with not significant weight loss, no blood in the stool, but he is having recurrent abdominal pain associated with diarrhea, mucus, and sometimes he might have alternating with constipation. When there is a chronic history, you can have to suspect this IBS. Investigations will help you to rule out other organic diseases like inflammatory bowel disease.
How often do you see IBS overlapping with anxiety or depression, and how do you address it?
IBS, anxiety and depression often overlap actually. I see often in the OPD, majority of patients, I can say anxiety with depression will be there with IBS, because it's a more of like it impairs the quality of life. Because many people, you can see in young people, they are daily going to their working place. They have to suffer with the working place because of this IBS symptoms. Few might have diarrhea, few might have constipation. They need to use regularly washroom there. So definitely, when the quality of life is hampered, definitely there will be an anxiety with depression, because they can't lead their normal life with their colleagues. So anxiety with depression definitely will coexist with IBS. One thing here is we need to treat these patients with utmost care actually, than just simple patients who are having just pain predominant IBS without anxiety. When patients with this associated anxiety and depression, we need to treat them with utmost care. We need to give them reassurance. We need to target them with gut-directed therapy. We need to add the neuromodulators also in this patient, psychological support. We need to take all this. Here, all people come into the role play actually. When gastroenterologist, psychiatry, dietitian, everyone will come into the role.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
Honestly, to say IBS diarrhea predominant is somewhat easy to treat in our OPD. IBS diarrhea, often patients says they complain of gastrocolic reflex. That is, they might feel like going to washroom after some time after intake of food. Frequently, they have frequent bowel movements. Sometimes they complain of with associated mucus and all this. Then here you have to think, is IBS diarrhea with pain predominant or like less pain predominant? You have to see. So IBS diarrhea, we often treat them with rifaximin. There is associated pain and bloating. We add probiotics also. Mostly they will do well with short course of rifaximin and probiotics. Again, if the recurrence of symptoms are there, we can add again one more short course of rifaximin. Coming to IBS constipation, it's a little tough to handle these patients actually. IBS constipation, we need to add fiber. We can't add more actually, because if there is a bloating again, too much of fiber increases the bloating. But still we have to give fiber with laxatives. We can have to consider secretagogues. Sometimes you need to add associated, rule out whether any dysenergic defecation is there or not. All this. So fiber, laxatives, secretagogues, and sometimes you need to add stimulants.
How do you decide when to repeat a course of rifaximin or switch to another therapy?
Yeah, we often see patients of initially they were very doing well when I started rifaximin and probiotics. Again, after 3 or 4 to 4 months, again they come back with relapse of symptoms. Again, I often give them the same course of rifaximin for a few days. Again, they'll do well. So if they are doing well with rifaximin, better to continue again the second course of rifaximin. But they are not responding to that, then you might think of changing the strategy of treating, whether to add neuromodulators and all those. Otherwise, repeating the rifaximin again to the patient, it will help actually.
Do probiotics or prebiotics have a role in IBS treatment?
Bloating, I think in IBS patients, they complain of bloating. I always feel bloated and all those. There are studies in the clinical trials, they showed that patients with predominant bloating and pain, and few pain patients, probiotics help. That you can give 4 to 6 weeks of trial. You can give probiotics. So in those patients who are having bloating and pain, you can give probiotics. It might be helpful.
What advice do you give to patients for long-term gut health and relapse prevention?
I think more of it not pharmacologically driven. It's more emotional driven. Irritable bowel syndrome is more of lifestyle related. Then comes this drugs. Mostly it says regular meals, good physical activity, adequate sleep, stress management, avoid unnecessary use of polypharmacy drugs from over the counter, taken from pharmacies. And more important is identify the food triggers. You need to identify your food triggers. Whichever the food triggers you are seeing, like you feel like your gut is getting upset every frequently, you need to take up them slowly.
How can physicians and gastroenterologists collaborate better for early IBS diagnosis?
I say it's more important from the physician's side also, because they often see the patients in the OPD, because with bowel upsets more of the time they feel like many patients they present to them with my bowel getting upset every time when I eat some food, or like when I often travel, I eat outside food, my bowel is getting upset, or like when I am eating immediately I'm going to the washroom. So more of them physicians also see these cases. One thing I have to say is early recognition, minimal testing, unnecessary testing we need not do in these patients. Stress management and timely referral with the dietitian, or sometimes they want to rule out organic disease like they are missing inflammatory bowel disease or not, you can refer to gastroenterologist for the colonoscopy and do some inflammatory markers like CBP, ESR, and fecal calprotectin to rule out IBD.
If you could give one takeaway to your fellow physicians about IBS, what would it be?
Yes, it says common, we often see in the OPD, treatable disease. So believe that we can treat, but it's more through an holistic approach. We need to be emotionally attached to the patients also. We need to counsel them more rather than writing the drugs or like treating. I don't say like treating the patient as IBS. I think more towards we need to have an attachment to the patient actually. Otherwise, patient can't get treated. He should be counseled well. He should be informed in prior, and he should be referred to the like psychological support, that is cognitive behavioral therapy. Suppose the patient is not getting well support from the drugs and diet, need to refer him for cognitive behavioral therapy. So I'd say one say to the physicians is IBS is real, common and treatable. Believe the patient.
One food you tell IBS patients to avoid?
I say is milk. Most often we Indians are lactose intolerant. So milk products, I often say in my OPD, kindly avoid the milk products. You can take yogurt, but anyway, multiple strains. Curd and yogurt can be taken, but milk products you need to avoid. Other foods like apple, few might be also having this. One food I say is milk products.
One word that describes a typical IBS patient journey?
If I say from my patients, I'm in the patient's side, it's frustrating for him actually. To be an IBS patient, it's frustrating, one word, because it hampers his quality of life. It's a long course journey, cannot take away these triggers. Sometimes again, you might have this recurrence of symptoms, all those. So it's a frustrating journey, but still it's treatable. Only one thing is we need to be patient when towards our approach. Everyone effort is required here, like from the point of the treating point of doctor, patient, dietitian, psychiatry, and still everyone.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.